Welcome everybody to our second talk of the semester in the IBS seminar series. I am very happy to introduce Brian Marein, who is a PhD candidate in the Department of Economics here at CU Boulder. He's on the job market right now. He's going to present his job market paper. I was going to say our job market paper. Sorry about that. I'm taking ownership of it, but I'm very excited as well because it's a very interesting topic, not only because, as Brian mentions in his abstract, right, Puerto Rico is one of the nations with the most rapid recorded mortality transition, but also because it speaks about this very important debate in historical demography, I think still today, the demographic transition, which is what is responsible for explaining this mortality decline, right? So the so-called Makion hypothesis, for example, and others, right? Other debates related to, for example, also the Preston curve, right, with regards to how much health does changes in GDP buy you and things like that. So Brian is going to speak about this in the case of Puerto Rico. He also holds, Brian holds a BS or a BA, I forget, sorry, Brian.
BS.
BS, excuse me, yes. In economics and in Spanish, graduating with honors from The Ohio State University. As well as holding an MA, of course, from CU Boulder in economics, and currently holds a so-called dissertation fellowship. So without further ado, thanks very much for doing this, Brian, and we look forward to your talk.
Yeah, thanks so much for that introduction. And also thank you for inviting me to present at IBS. I'm really excited about getting to present in front of an interdisciplinary audience and getting feedback, hopefully from people in disciplines outside of economics. So as you mentioned, this is my job market paper and a chapter in my dissertation. The title has changed a little bit from the IBS, or what's being shown by IBS. It's now public health and the first mortality transition in the tropics. And I'll take about 40 minutes and looking forward to questions and comments. Also feel free to interrupt. The convention in economics is to constantly interrupt the speaker. So if you have a clarifying question or just want to make a point and don't feel like typing it, don't feel bad about interrupting me. Okay. So it sounds like maybe people in this audience are familiar with the mortality transition and the demographic transition, but I'll talk a little bit about it anyway. It's hard to think of an event or a series of events that's had a more positive impact on welfare than the doubling of life expectancy, and in particular, that children die at rates far below historical averages. If we take a look at this graph, we see that the mortality transition started in Western Europe and European offshoots in the 19th century, and then spread to the rest of the world in the 20th century, particularly after World War II. It's not just that different regions of the world experience this transition at different points in time. There's also a lot of variation in the success of the mortality transition. Factors like the age at which life expectancy plateaus, and also the time that it takes to get from, let's say, pre-modern to modern health outcomes. And when we think of the causes of this transition, obvious factors are economic growth, improvements to nutrition, medical technologies available, and also the effectiveness of public health. And when we think of countries that have had particularly effective public health, even today we're seeing it, but we might think of Japan, Korea, countries in East Asia that very effectively transition their societies through this process. But if we take a look at the largest increases in life expectancy over a fixed period of time, actually Puerto Rico stands out as one of the most successful cases. What you're seeing here is, for all countries and territories on Earth, the largest increase in life expectancy over any 30-year period. And I've highlighted a few of the countries just for reference, but we see Puerto Rico all the way over there to the right. Between 1930 and 1960, life expectancy in Puerto Rico increased by 29 years. And this was the largest increase over any 30-year period anywhere on Earth up to that point in time. And since then has only been surpassed on a few occasions. By 1960, Puerto Rico is a world leader in health outcomes. Here you can see they're on par with the United States in terms of life expectancy, ahead of the rest of Latin America, and also ahead of all the countries in East Asia that again, we often associate with excellent public health in the post-war era. So from this, it's fair to say that Puerto Rico was the first area outside of Europe and what we often call European offshoots to complete the mortality transition. Part of what makes this so remarkable is that Puerto Rico, of course, is a tropical island, and so was susceptible to tropical diseases, especially malaria, and also had one of the highest rates of tuberculosis mortality in the world in the early 20th century. So given the success of the mortality transition in Puerto Rico, I want to know more about what made it so successful. And specifically, I want to focus on public health. Much of the mortality transition in Puerto Rico coincided with post-war industrialization, when Puerto Rico was one of the fastest growing economies in the world. And so for past research, it's been easy to write off public health. But this is surprising because there were such large changes and expansion of public health services in the years leading up to and in the early years of the mortality transition. And so I think that this warrants reinvestigation. While I can't focus on all aspects of public health, I focus on the cornerstone of the Puerto Rican public health program, which was public health units, or what in the American context were called county health departments. And I'll talk more about what these were in a few slides, but essentially they were local health departments that provided free and mostly preventative healthcare services. And so my research question is, were public health units responsible for the initial decrease in mortality in Puerto Rico? And really to what extent were they responsible? To be able to measure the effect of health units on mortality, I exploit temporal and municipal variation in an event study. And again, I understand that this is an interdisciplinary seminar, so I'll do my best to sort of explain the logic behind an event study once I get to the formal analysis. But what I'm doing is I'm using the fact that each municipality or county in Puerto Rico opened one of these health units, but they did so in different years between 1926 and 1937. And so I'm seeing how mortality changes in the years before and after municipality opens its health unit, and I'm comparing that to patterns in municipalities that opened their health units later. And so I'm making this assumption that in the absence of a public health unit, that the different municipalities would see their mortality rates change in a parallel fashion. And again, I can talk more about that once I get to the formal analysis. To be able to study this historical episode, I've built a new annual municipal level data set for several mortality outcomes from Department of Health reports. And this is a really major contribution to the paper because there's this big growing literature in economic history that looks at historical health interventions to see whether they were effective. But it focuses exclusively on Europe and, again, what we might call European offshoots. In specific, they focus on Scandinavia and the United States. This makes sense. This is where the data are. But it's unfortunate because it excludes most of the world. It excludes Latin America, Africa, and Asia. And even today, most areas of the world don't have complete registration of deaths. And you can imagine that was even more so the case in 1930. But Puerto Rico, by virtue of being a US territory, had granular, consistently reported, and fairly reliable vital statistics by virtue of being, again, a US territory. And so this paper takes an important step in bringing the literature into Latin America, and hopefully will motivate further investigation in the region. Also, because this intervention occurred during the period of direct rule by the United States, I'm able to provide a descriptive account of public health to inform the empirical analysis. Before I mentioned that there's this debate within the study of Puerto Rico about whether economic growth or public health was more important, or the extent to which each was important in the mortality transition. But this contributes to a larger debate across the world about the importance of economic growth relative to public health. And of course, these processes they don't happen in isolation, they're interrelated. Public health has to be funded through tax revenue, of course, which is related to economic growth. But the point is that we should sort of simplify this comparison and think of the direct effect of each. So you can have economic growth without public health if politicians don't channel money into public health. And likewise, you can have public health without economic growth raising taxes, by getting funding from external sources, or by repurposing public revenue. And lastly, this paper contributes to sort of a secondary debate in the literature that focuses on the effect of anti-tuberculosis efforts in the era before antibiotics. And this is an important debate to be had because tuberculosis continues to be a major problem in developing countries, and there's a growing crisis of drug-resistant tuberculosis. So this is an area where history can inform modern policy. And again, I don't know the convention outside of economics, but in economics, we share our results before we talk about the investigation. So if you're waiting for a surprise at the end, unfortunately, that's not going to happen. I find in my investigation that health units were responsible for most of the decline in infant, maternal, and tuberculosis mortality, and about 1/3 of the decline in overall mortality through 1945. The body of evidence also suggests that health units reduced stillbirths, but that they had no effect on malaria mortality. And this is consistent with the historical record. Essentially, the Department of Health in Puerto Rico lacked the financial resources to be able to effectively combat malaria until the run up to World War II, when US troops were stationed on the island and the federal government took over the eradication of malaria. In a few slides, again, I'll talk more about what it is exactly that health units did. But one challenge in this paper is that it's difficult to know exactly which services mattered because health units provided such a wide range of services. So while I can't pinpoint exactly which services mattered, what I will show is that the number of per capita nurses and per capita number of midwives is associated with larger decreases in infant and maternal mortality, whereas the number of sanitary inspectors, which is the other major employment category at these health units, that's not associated with any of the changes in mortality outcomes that I look at. And at a minimum, this does suggest that the work of nurses, particularly prenatal clinics and home visits, as well as the training and licensing of midwives, was more important than, say, the enforcement of sanitary regulations or improvements to rural sanitation. This also fits very nicely with some recent papers that have come out in economic history that have shown that prenatal clinics, home visits, and the training and licensing of midwives was instrumental in reducing infant and maternal mortality, both in Scandinavia and the United States. I won't really get to talk about it today, but I find that rural areas experience larger decreases in infant mortality, and this is consistent with the stated goal of the health units to bring health services to areas which previously lacked access to professional services. And then finally, hopefully I'll have a little bit of time at the end to discuss expenditures. Part of what makes this program so remarkable is that it was carried out during the Great Depression at a time of falling tax revenue and also diminishing external funding. And yet they continued to roll out the program and also keep up with their other obligations. And so using these expenditure data, I do sort of a back of the envelope cost benefit analysis and estimate that the benefits of the program exceeded cost by a ratio of 22-to-1, which shows that this was a very cost-effective program. So again, it's important to talk about what exactly health units were before jumping into data analysis. And essentially what was going on is that in the early 1920s, the Department of Health in Puerto Rico was starting to expand the services that it was providing. But there was growing consensus within the department that it was inefficient to have everything run out of the central government in San Juan. That the idea was that bureaucrats in San Juan lacked the local knowledge and expertise to be able to identify and properly respond to problems at the local level. Puerto Rico is a small island, but it's very diverse geographically, economically, demographically, and so forth. And so the Rockefeller Foundation had been involved in the rollout of county health departments in the United States and proposed that Puerto Rico adopt a similar system and that they devolve authority to the local level, have everything coordinated at the local level. And so the Department of Health in Puerto Rico agreed to do this with the guidance of the Rockefeller Foundation, starting on a trial basis in 1926. Health units were responsible essentially for coordinating all community health efforts, both public and private, but specifically they were charged with the study and control of transmissible diseases, health education, medical inspection of school children, health promotion by prenatal, infant, preschool, and tuberculosis clinics, and also the control of general sanitation. So again, they carried out a very wide range of activities, some of which were the continuation programs that had already existed, but many of the programs were brand new. So medical inspection of school children had only existed in the more developed areas of San Juan, for example, before this, and the same goes for prenatal clinics. You wouldn't have found those in most areas of the island prior to this program. To be even a bit more specific, here's the highlights of health unit activities for fiscal year 1938-39, the first fiscal year in which all municipalities had a health unit. The population of Puerto Rico in this era was 1.8 million. And so this hopefully helps to give an idea about the size of the program. So they estimated that in this fiscal year, 1 in 4 pregnancies was being handled by a health unit. So this doesn't mean that the health units were a hospital and delivering the children. That's not what they were doing. But they were helping with prenatal care and also monitoring the health of children after birth. And so it's clear that health units were a central institution in Puerto Rico in this era. And again, what you're seeing here is like a summary or highlights, and it's not an exhaustive list of activities that were carried out. As I mentioned before, each municipality or their county equivalents in Puerto Rico, each opened its own health unit between 1926 and 1937. And here you can see what the rollout of the program looks like, that these are new units opening by fiscal year. And you can see it started off slowly because the program was on a trial basis initially, and then it was quickly ramped up in the early and mid 1930s until 1937 when each municipality had its own unit. This is what the rollout looked like over time and space. And it's not so important to look at like the specific dates of each opening, just to give you a general sense of the spatial pattern of these openings with lighter shades representing earlier health units. And you can see that like I provided labels for the most important urban areas of Puerto Rico, and those are generally lighter shades. So it's not surprising that more urban areas open their health units earlier. Unfortunately, not a whole lot is known about why municipalities opened a health unit the year in which they did, other than the first few. So the first municipality to open a health unit was Rio Piedras in 1926. And that was done because it had both a large urban and a large rural area, and was part of the sugarcane region, which was the most important export crop at the time. And so this was specifically chosen to sort of represent different areas of the island to see how the program would work, working with different communities. From there, they then picked a municipality of the tobacco region, a municipality of the coffee region, again, to represent the different areas. And once they were convinced that the program would be effective, then they rolled it out to the rest of the island. So I perform a simple exercise just to more formally assess like what explains treatment timing. And so this is just a simple OLS regression of the year in which a municipality opens its health unit, and then regressed on some characteristics of the different municipalities. And again, it's not important to focus on anything in specific here. It's just to see general patterns. And what we see is that more urban areas, again, opened their health units earlier. About a quarter of health unit funding was expected to be borne by municipalities. And so more urban areas would have both more tax revenue and probably more competent administration to be able to open these health units. So again, it's not surprising. That doesn't necessarily affect the event study, but I can talk about that more once I actually get to it. Again, one of the major contributions of this paper is the data set. So these data have been sitting in libraries for years, but have gone mostly unused. And so I have digitized this big new data set for all municipalities for the years 1923 to 1945. I can look at all-cause mortality, infant mortality, tuberculosis mortality, maternal mortality, malaria mortality and stillbirths. Unfortunately, malaria or maternal mortality is missing several years of data, and so I don't include it in most of the discussion. You'll see it at the end, but just to give you a heads up for why you're not going to be seeing that in the initial results. And what I'm going to show, these are all rates. So, so mortality is going to be rates per population, and then anything involved with childbirth. So maternal mortality, stillbirths, infant mortality, that's all going to be a rate as a share of births in that year. Before jumping into the formal analysis, I think it's helpful just to take a look at mortality rates in the long run. And here you're seeing a 3-year moving average of mortality between 1888 and 1960. And so you'll see a few things here. First, of course, there's a major drop-off or a spike and then a drop-off in mortality at the time of the Spanish-American War in 1898. But the drop-off after the war it actually takes mortality to a level far below pre-war levels. So there were significant public health measures taken initially by US occupation forces during the brief military occupation, including, for example, a universal smallpox vaccination campaign. So we do see this big change relative to earlier mortality, but then more or less for the next 20 years or so, 20 or 30 years, there's not any real trend in mortality. There's a big spike, of course, during the influenza pandemic, but we see, even with significant year-to-year variation, we see mostly flat mortality. It's not really until the 1930s that we start to see this renewed decline in mortality, and this accelerates in the 1940s and 50s. But it's around the time that these health units are opening that we're starting to see a renewed decline in mortality. And so this does provide some, I think, motivating evidence for the rest of the analysis. The event study that I mentioned before, is the specification is shown here. And so again, what I'm doing is I'm regressing log mortality rates for each municipality. That's mortality MT is mortality in municipality M in year T. And that's regressed on year and municipality fixed effects. So municipality fixed effects are controlling for any conditions in a municipality that do not change over time, but that are correlated with mortality. And the year fixed effects are controlling for any time trends that affect the island altogether. So they're not municipality specific, it's just dealing with general changes throughout Puerto Rico. The identification of the effects of health units is going to be seen with these PHU dummies. So PHU-MN is a dummy variable equal to 1 if municipality M is N years away from the opening of their from the opening of their health unit. So what I'm going to do is I'm going to be able to see how mortality changes for 4 years leading up to and 7 years after the opening of a health unit, after controlling for these general time trends and controlling for any municipality specific characteristics that affect mortality. And so what I'm doing is I'm assuming that mortality is going to be evolving in a similar fashion across municipalities in the absence of the opening of a health unit. And this is actually, I think, a really reasonable assumption because, as we saw before, and what is consistently said in the official records, is that most of the major changes to public health under American rule occurred in the first few years of U.S. rural Puerto Rico, and that we don't really see any major changes in public health until the rollout of these health units. And so it's reasonable to think that mortality is going to be evolving in a similar fashion across municipalities. So what you're seeing here is the results of this event study with these years on the bottom are showing you years relative to treatment. And so what you're seeing before program inauguration is that mortality is not trending, and it's not, there are no significant spikes or trends in mortality leading up to a program inauguration. And so this helps to support the assumption that municipality is evolving, or that mortality is evolving in a similar fashion or a parallel fashion across municipalities. After program inauguration, so that's in year 0, we see a 4% decline in the first year for mortality, and then this effect grows to about 10% over the next several years. For infant mortality, you see a similar pattern. So there's, again, no significant changes to mortality in the years leading up to program inauguration. Just to be clear, we would be concerned about inference if we saw like a downward trending line going this way, because then we might think that, well, really, it's just that mortality was already declining, that it's not attributable to the health units, but that's not what we're seeing. We see this decline in mortality only after program inauguration, and in this case, it's about 6% decline in infant mortality and grows to 10% over a few years. Actually, in some of my preferred specifications, the effect is quite a bit larger. It's more like 15% decline in infant mortality. Again, I'm not going to spend so much time on each of the event study results, but you see a similar pattern across the different outcomes. For TB, the effect is a little bit delayed, but actually quite a bit larger. So in this specification, I estimate that it's about a 20% decline in tuberculosis mortality attributable to the health units. And for stillbirths, we see a similar pattern, although none of the effects that I estimate are statistically significant. Still, this doesn't rule out that there was an effect on stillbirths. Across specifications, I consistently find this negative effect, even if it's not statistically significant. The very large confidence intervals, though, are consistent with an explanation of measurement error in the dependent variable. So stillbirths are going to be measured with quite a bit of measurement error. There's still no universal definition of what constitutes a stillbirth. So in the numerator, of course, that's an issue. And then also likewise in the denominator, births were severely underreported in this era. So only 80 to 90% of births were reported. And so on both sides of the ratio, you're going to have measurement error. And so with measurement error, it doesn't affect the coefficients, which are the black dots that you're seeing, but it does affect the confidence interval. The last one I'll talk about here is just briefly malaria mortality. There is a decline in this result, but it goes away very quickly. What I can say is that the pattern of the coefficients is very sensitive to specification, which is not true of any of the other results. Often I see a flat line or even a slightly positive effect on malaria. And so I can rule out that there was any effect on malaria mortality. As I mentioned before, I can't say exactly which services mattered. And unfortunately, I don't even have yearly data for the different inputs or the employees of the health units. So what I'm going to do is I'm going to use the only data that are available, which is a snapshot of employees at the health units in 1935. The two main employment categories were these public health nurses and sanitary inspectors. And so I can observe the number of each of those for 55 municipalities that were treated in 1935. And so what I'm going to do is I have to assume that the distribution of nurses and sanitary inspectors per capita across the different municipalities is relatively similar over time. And I'm going to show how the effect of health units differed based on the number of nurses and sanitary inspectors per capita. So I'm going to interact a treatment dummy with both of these per capita measures. And I want to emphasize that I'm not trying to claim causality here. Of course, the number of nurses or sanitary inspectors per capita may be endogenous to mortality conditions in municipalities. They may be correlated with other aspects of the health program, but nonetheless, this does provide some suggestive evidence of what was responsible for declines in mortality. And so in this first table, taking a look just at nurses in 1935, we see that municipalities with more nurses per capita experienced larger declines in infant mortality. So about one additional nurse per 10,000 inhabitants is correlated with an additional 10% decline in infant mortality. And again, these are suggestive results, but they're consistent with what we would expect to find. Nurses spend about 3/4 of their time on child and infant health. And so the fact that we do see larger effects with more nurses is not surprising. For sanitary inspectors, we don't see any significant effect across the board. And in fact, the coefficients are all very close to 0. And so this suggests that that none of the outcomes that we're looking at were correlated with the number of sanitary inspectors per capita. The other group that I want to talk about are midwives. So I think that this intervention is really interesting and it's a little bit different. So let me just spend a little bit of time explaining it. What happened is that in the early 1930s, the Department of Health was studying infant mortality, and they realized that the vast majority of deliveries were being handled by women in the community who had no training in cleanliness or in anything medical related. And so these officials in the Department of Health thought that ideally they would have all deliveries being handled by doctors or by college-educated midwives. But of course, this wasn't realistic given the development of Puerto Rico at that point. And so instead, what they did is they built a new category, a new medical category on top of the system that had already existed. And they created this category of assistant midwives. So all this is that they were taking the practices that were already common throughout the island and imposing more structure on it. So these women in the community who were helping with deliveries were now, they were allowed to continue helping, but they had to be trained and licensed by the public health units. They had to come to a health unit once a week over the course of several months to learn just the basics of cleanliness and the use of soaps and disinfecting utensils used in delivery and so forth. And they were required to buy some basic equipment to be used. And so the idea was to improve the quality of services that were available on the island without making the services so expensive that there would be like a new black market for midwives. And so what I'm going to show is, again, it's just a snapshot. It's looking at fiscal year 1935-36. The number of assistant midwives per capita is interacted with a dummy variable that's equal to 1 for all years after 1931, the year in which the licensing law took effect. And so this is going to allow us to see how outcomes changed with the number of midwives per capita. And once again, we see results that are consistent with what we should expect to find. So the number of midwives per capita is associated with larger decreases in infant mortality. So an additional midwife per 1,000 inhabitants is correlated with about a 14% decline in infant mortality. We see an effect about half the size for general mortality, but of course that may just be a mechanical effect coming from a reduction in infant and maternal mortality. And finally, the really big difference that we see is for maternal mortality. And this really is what we should expect to find. So maternal mortality declined by about 60% between 1930 and 1945. Part of this has to do with the introduction of sulfa drugs in the early 1940s, but even prior to that, we saw very large declines in maternal mortality. And so, yeah, an additional midwife per 1,000 inhabitants is correlated with around a 40% decline in maternal mortality. For the sake of time, I'm going to skip this for now. It's not super important. So I just want a little bit of time to talk about expenditures and a little bit about the cost benefit analysis that I do. So part of what made this program so remarkable, like I said, is that it was carried out during the Great Depression at a time of falling tax revenue, at a time of declining external funding. And so what we see in the first row of this table is that the total expenditures on public health units by the Department of Health is actually declining in the first few years of the 1930s. And yet in the next few lines, we see that the number of municipalities and the total population treated by these health units is increasing. So they're still managing to roll out the program at a time where costs are, or where expenditures are decreasing. And at the bottom, you can see the per capita expenditures, which also I think is pretty impressive to put this in perspective. So throughout the 1930s, the health department was spending about $0.25 per person on health units, and that comes out to less than $5 a person in modern dollars. It would be great to know exactly how they were able to pull this off, how they were able to roll out the program during a time of falling revenue. And I don't know exactly how it was done, but it is something that officials within the department knew was a very impressive accomplishment. They talked about how they were cutting costs everywhere they could to make room for these health units. In the early 1930s, they cut salaries across the board by about 10%. They emphasized that they were always looking for unnecessary expenditures to cut. And yet, if you look at expenditures at the other major health institutions in the Department of Health, so for example, the district hospitals, the tuberculosis hospital, the blind asylum, and so forth, you also see reductions in aggregate spending, and yet you're not seeing declines in the number of patients served. So during a very difficult economic period, the Department of Health was, again, reducing expenditures without severely cutting back on any of its major programs. So I think that's a really remarkable achievement, and also provides hope for departments and agencies that are dealing with reductions in spending. Looking at the total expenditures of the Department of Health, not just on health units, this confirms what I was saying before, that really we're not seeing any major increases in health department spending until the run up to World War II. So during the full rollout of the program through 1937, we're not seeing an increasing trend in expenditures. In fact, we're seeing declining expenditures for several of those years. And so before I mentioned that I carried out a cost benefit analysis, and again, I really want to emphasize that this is not meant to be super precise. There are lots of different assumptions that go into this cost benefit analysis, but nonetheless, it does give us some sense of the effectiveness of the program. And so what you're seeing is, first of all, I estimate for the years 1932 to 1939, the years in which I have some cost data, I estimate the number of deaths averted. So these all come from the event study that I talked about before. I simply, I estimate the model, and then I impose that municipalities never opened a health unit. And from that, I can estimate the number of deaths averted. And so over this period, I estimate that they saved about 7,000 lives, or almost 18,000 lives. Of course, this is an estimate, and so I have lower and upper bounds as well, and you can see those to the right. From there, I take a value of statistical life from another paper. So this is for 1940, and I believe it's for working age adults in the United States, and I simply adjust that for the income of Puerto Rico at this time. This is probably a conservative estimate because so many of the lives that were saved were for infants and children. And the most recent papers on value of statistical life suggest that actually the value of a child's life statistically is much higher. But in any case, from that, I simply multiply the number of deaths averted times the value of statistical life to estimate the benefits of the program. The cost of the program is also an estimate. So the only costs I observe are for the Department of Health. Initially, the Department of Health was supposed to cover half of expenses. And I don't observe how much they actually ended up covering, but all of the later reports suggest that they ended up paying the lion's share of expenses, that in the end, the Rockefeller Foundation only helped out with a few of the units, and that that municipalities largely were not able to cover their own expenses. And so what I've done is I've taken costs by the Department of Health over that period and multiplied it by 2. And this is, again, probably a very conservative estimate of costs. But in any case, even so, I estimate that benefits exceed costs by a ratio of 22:1. And so just wrapping up to leave plenty of time for questions. Once again, I've found that public health units were responsible for very large decreases. In fact, most of the decrease that we see in TB, infant and maternal mortality, probably stillbirths as well. If I just pick 1 year, so one of the later years, 1940, I estimate that health units saved 3,430 lives that year, including 907 from tuberculosis and 1,766 infants, not including stillbirths. The last few slides, I talked about how much of the program was accomplished through improvements in administration and cost reductions. And again, I think that this makes the story a lot more interesting. When many people think of Puerto Rico, I think that they think of these huge transfers from the mainland. And so, like, for example, it's misleading to just look at Puerto Rican GDP per capita because of huge transfers from the United States. So it actually exaggerates the development of the Puerto Rican economy. But in this case, it's not really true. The federal government was involved in this, as was the Rockefeller Foundation, as were private charities, or other charities, I suppose. But most of this was accomplished by the Puerto Rican Department of Health, again, through improvements in administration, and not just simply by throwing money at a problem. They recognized the inefficiency of their administration in the 1920s and made improvements to provide a more cost-effective program. This paper suggests the importance of prenatal clinics, home visits, and occupational licensing. And these are 3 interventions that, again, have been highlighted in research on Scandinavia and the United States to suggest that these are all interventions that were very important in the mortality transition in these countries. And finally, I think that this paper takes an important step in bringing the literature into Latin America. So often Puerto Rico is excluded from discussions of Latin America because it's not an independent country. And so people think that its experience is not similar enough to that of independent countries to make it worth including in those discussions. But this is, I think, definitely an exception to the case. Most countries in Latin America adopted local health departments following the Puerto Rican example after Puerto Rico did. And they did so with guidance and also financial help from the Rockefeller Foundation and also from US federal agencies. So really the experience of other countries in Latin America may not be so different in this case. And so hopefully this provides a window into Latin America and also motivates further research into public health in Latin America. And that just about wraps it up just in time. So I look forward to comments and questions.
Thank you very much, Brian. Would people like to ask questions and to do so directly to Brian instead of through the chat? But we can otherwise repeat whatever you write on the chat, whatever you prefer. Jane. I think you might be muted, Jane.
I was trying to get the cursor over there to unmute. Brian, this is really good work.
Thank you.
A very interesting study. My first question is, what were the services that could be provided that reduced TB so much? I can understand it's so shockingly easy to reduce infant mortality when it's high, that I can well understand your findings. It's what could they do about TB that I'd like you to talk a little bit more on.
Right, so that's a really good question. And this puzzled me a little bit at first until I started both looking into the historical record and then also leaning very heavily on modern research into public health. So there are two aspects of it. The first one I can't really speak to because since it's not widely practiced anymore, there's not good information about whether it's effective. One aspect is that in the tuberculosis hospitals, they were carrying out lung collapse therapy. So surgeries to collapse the lung and induce recovery. I have no idea the extent to which those were effective, and you look skeptical. The part that they emphasize, though, is mostly detection, isolation, and contact tracing. Suddenly with these, with school examinations, they had universal examination of high school students who seemed to be more susceptible to tuberculosis. They had a team of traveling tuberculosis clinics that would go and take x-rays of the population. So the health units themselves were mostly a case finding agency. So they were trying to identify cases of tuberculosis. And from there, they would take positive cases to the two hospitals, two sanatoria, to be in isolation and recover. In some cases, I still can't find this, but I recall reading it at some point in one of the reports that they would hire high school students to build shelters for people to self-isolate in. And then they had a very extensive case finding agency. I should have mentioned as well, they provided quite a bit of information, both in like house to house campaigns and then also just distributing literature about how tuberculosis is transmitted. And so one thing that they were very proud of in these reports is that they claim to have a more like dedicated and more effective team of contact tracers. So they described it as a system from which the patient could not escape, that they monitored where they were when they went back to their homes after recovery. They continued to monitor them. They would take them to treatment when they lacked resources to travel. And so those all seem to be possible explanations for the decrease in tuberculosis. And thanks for the question.
I have a lot more, but somebody else should be asking questions.
Okay, well, maybe we can come back to if other people don't ask questions.
Rick has one.
Brian, I enjoyed the presentation. It was quite interesting. It's useful to look at the mortality transition and to include Puerto Rico, which you're right, has been overlooked for a lot of studies. You made a strong case for public health units and how important they can be. But it seems that I was still left wondering whether socioeconomic status may have been understated. You mentioned that you controlled for literacy, but I don't know that you controlled for income, or literacy might be a little bit too broad. It could be other educational levels. And some people look at health behaviors. So whether health behaviors changed over this point. So I looked through and think there could be a few other factors, and I wonder whether public health units may have been slightly overstated.
Yeah, thanks for that input. Yes, I do want to emphasize that I'm both showing that health units were very important, at least through 1945, but I'm not ruling out the importance of other aspects of society in Puerto Rico at this time, particularly after 1945, when there's new medical technologies available and when the country is rapidly industrializing. So actually the decline in mortality and the increase in life expectancy accelerated in the 1940s. And so this investigation may not be so applicable. I probably couldn't say that health units were responsible for most of the decline in the post-war era, for example. Also, malaria was eradicated in the 1940s through the use of DDT. And that we see a huge decline in mortality from malaria in the 1940s. And so aspects other than health units definitely mattered. And so, yeah, maybe I can do a better job of talking about some of those other factors moving forward, and also providing a little bit better explanation in the paper.
Thanks. Yeah, I think health units are important, but you kind of captured a period too that's going to be more amenable to interventions in infectious diseases. And some of the conditions that are going to be more important from the 1940s forward are going to be chronic and degenerative diseases. And so whether health units will continue to be as important still remains to be seen.
Right. I think that's a really important point. I mean, so much of what they were accomplishing was mostly through education, particularly about infant and child health. And once that information is distributed and it's widely known among the population, then there's going to be diminishing returns to the health units. And so you're exactly right that as infectious disease fell and life expectancy increased, and there's more problems with chronic and degenerative disease, probably health units sort of faded into non-existence. And in fact, when I've been trying to follow the evolution of these health units after the period that I'm looking at, it's very difficult to find information about them. It is almost as if they just fell out of use. And so, yeah, those are all really good points. Thank you.
Anyone else before I ask a question or Jane goes? We go back to Jane.
You go first.
Okay, thank you very much for the talk again. I had a similar question with regards to what Rick just said with regards to, for example, when he was mentioning behaviors. I see you have a paper as well that relates to anthropometric measures. So is it during the same period? And how would you combine or well, could you like walk us through a little bit of what you found in the other paper?
Yeah, sorry, your screen froze for a second. And so I decided I didn't hear your question.
So I was saying that I wonder if the some of the aspects that Rick mentioned with regards to other changes in health behavior, so to speak, relate to some of the aspects of the paper you wrote on anthropometric measures. I don't know if they're during the same period. I saw you have that as another paper in your dissertation. Right. And I don't know if it's relevant. Could you walk us a little bit through those results?
Yeah. So what I found in that paper is that there's an increasing trend in adult height in Puerto Rico in the period of direct rule by the United States, which other anthropometric research has found that the childhood disease environment and nutrition in childhood are the two factors which seem to have the most important effect on trends in adult height. And notably, there's not much immigration during this period. And so it is sort of like we're looking at the same group of people over time. Yeah, so in that paper, again, I find this increase in height, and I can't tease out, just because the data are not detailed enough, I can't tease out the extent to which this is due to changes in nutrition or changes in the disease environment. I mentioned before that we do see a decline in mortality immediately after US annexation, and so probably that had some effect. And then we see the improving disease environment in the 1930s as well, but probably a lot of it has to do with nutrition. So over this period, Puerto Rico's external trade was among the fastest growing in the world. And so along with along with exporting a lot more, they were also importing a lot more foodstuffs. So often this is assumed by some that this means that there's worse nutrition, but in fact, Puerto Rico all of a sudden had a much greater availability of a greater variety of food. So wheat from the United States, salt cod from Canada, and in particular powdered milk, which was not widely accessible prior to American rule, suddenly became a very important part of the Puerto Rican diet. And so, yeah, I think that these papers are related. It's just very difficult to know the extent to which they're related.
Okay.
Brian, I'm really interested in the health centers themselves. You said this was decentralization, but you've talked about health centers as if they were monolithic. And I don't know if you're aware of the project in Honduras being led by Krista Anderson on decentralization of health services in modern day. And so you may want to talk with that group about some of the differences we're finding in what kind of units led the health services post-decentralization. And so I wonder here whether you have evidence of training, of directives, of how the health centers themselves were managed so that you can possibly look at differentials then in outcomes according to input of to health centers or of health centers.
I agree with you. So I mean, I'm imposing the assumption that these health centers are all providing, you know, a similar benefit across municipalities, but it's doubtful that that's true. Yeah, the whole project was part of a decentralization of health services. So the Department of Health was still setting policies, but then they were being tweaked depending on local conditions. Ideally, I would know more about what each health unit was doing. I have not been able to find much information other than the snapshots of those employees in 1935. It's possible that more information exists either in Puerto Rican archives or in the Rockefeller Foundation archives in New York. But right now, both of those archives are inaccessible. So maybe that'll lead me to further research down the road. But I take your point, and I agree it would really help the investigation if I could talk more about that. Thank you.
Thank you.
Anybody wants the last question?
I'm curious if you had to say sort of the biggest policy takeaways if we were trying to design smart policy now in Puerto Rico in similar kinds of contexts. I know, you know, as an economist, you're sort of trained to drill down into the specific you're looking at, but like if you're speculating to broaden it out, if you feel comfortable with that.
Yeah, I mean, I think it's really hard to say. So in the Puerto Rican context, I don't think that this has much applicability at all. Puerto Rico, looking at indicators other than income, is on par with developing countries, and so interventions to help infant mortality by teaching people to wash their hands and breastfeed, I don't think is super important. I mean, I am, maybe I'm too influenced by reading the official reports, but I mean, they really emphasize that it was so important to have all the services coordinated at the local level with someone who was part of the community, who was living there and observing the habits of the people in the community, to be able to respond to them. Whether that's because they could better identify or they were more trusted by the community is unclear. But I do think that some level of decentralization, some level of local control can really be effective here. And sorry, that's one thing that I want to emphasize as well here, that this is a case of sort of like of external aid, and we think of Puerto Rico, it's being ruled by the US, but this is mostly a homegrown program. That the Rockefeller Foundation helped to train people, but these are all like Puerto Rican women who are carrying out this program as nurses, and that alone, I think, might have been important as well. They talk about how it was important for them to erode distrust of healthcare professionals because people had just not come into contact with them before. And so having people who are part of the local community actually carrying out the services, that could have been important as well. But again, that's just speculation. So that's beyond my role as the economist.
But it's interesting. You're so deep into this case. It's interesting to hear your speculations. Thank you.
Okay, with that, thank you again, Brian. We've come to the end of our time, but thanks very much for the talk. And yeah, I was wondering actually if this trust also related to some of the reproductive health, the birth control pill, basically experiments that happened, but I don't remember exactly when that was in Puerto Rico.
Yeah.
Earlier.
Yeah, that's mostly after the war.
Oh, after the war. Okay.
Much later.
I've gotten this question before, and actually the leaders of the health department prohibited people from discussing birth control or contraception in the health units. And so this was decidedly not a part of any of that.
Fair enough.
Yeah.
All right. Well, thanks again for a very interesting talk.
Yeah, thank you so much.
See you everyone next week.